Chapter 34 is going to be on the interpretation of periodontal disease in dental images, and it's going to start on page 413. Learning objectives for this chapter will be to define the key terms associated with interpreting periodontal disease. We'll discuss the healthy periodontium, what that looks like on a radiograph, and we'll briefly describe periodontal disease. You will have a whole other term, a whole other course on periodontal disease. So we will certainly not get into all of the nitty-gritty that goes into that. We'll need to be able to do the following related to the detection of periodontal disease. So discuss the importance of the clinical exam, discuss the importance of dental image exam, including different techniques used, describe the limitations of dental images in the detection of periodontal disease, and describe the type of dental images that should be used to document periodontal disease and the preferred exposure technique. You'll need to be able to do the following related to the interpretation of periodontal disease on dental images. State the difference between horizontal bone loss and vertical bone loss. State the difference between localized bone loss and generalized bone loss, and to state the differences among mild, moderate, and severe bone loss on a radiograph. You'll be able to list the American Dental Association case types and describe the corresponding appearance on dental images and recognize the ADA case types on dental images. And we'll also list predisposing factors for periodontal disease and recognize and describe the appearance of calculus on dental images. Okay, so what are we doing this for, right? Honestly, I feel like everything you've learned up until this point has been for this. As dental hygienists, going to hygiene school, taking radiology, your entire course has been to bring you up to this point, bring you up to this chapter, specifically as a dental hygienist. Yes, chapter 35 and all of those other chapters mattered. All of those chapters have value, but this one is the one that all of those other chapters are for. This is what you need to know as a dental hygienist. This is our main this is the whole reason we're taking this class. So we need to introduce you to the description and the detection of periodontal disease. That is what we do. So we're going to talk about the image interpretation for periodontal disease. We're going to specifically be looking at bone loss, the ADA case types, and the identification of predisposing factors. So we'll talk about a little bit of predisposing factors for periodontal disease, but not a whole lot. Mostly just the things we see radiographically. Unfortunately, I can't teach you the entire term 4 perio course, right? So, well, not in this one anyway. Dental images play an integral role in the assessment of periodontal disease. There is no diagnosing or determining periodontal disease without dental images. So first, we need to review a little bit about those structures that give us the information that we need for periodontal disease, right, to determine healthy versus unhealthy. So the first up is the lamina dura. This is something we talked about in chapter 27. The lamina dura appears as a dense radiopaque line in healthy teeth. It is the dense cortical bone that separates, that ends the alveolar process. Then there's the PDL, the periodontal ligament space, that where all of those fibers attach and reach out for the cementum of the tooth. And so the lamina dura tells us a lot about the health of the bone, the alveolar bone, in relation to periodontal disease, right? Because periodontal disease is literally the alveolar process, the bone that is there. The disease is when we start to lose that bone. Periodontium, which refers to the tissues that surround and support those teeth. We can see lamina dura on figures 34-1 on page 414, figure 34-2, and 34-3 as well. Those are all three examples of what healthy periodontium looks like. When we're looking for the alveolar crest, or the crestal bone that is interproximal, that's in between teeth, we're looking for about 1.5 to 2 millimeters worth of space in between the CEJ and where that crestal bone crests, right? Where the top of the crestal bone. So if it's farther down, if it's receded, if there's more than 2 millimeters worth of space between the CEJ and of those adjacent healthy between where the CJ is and then where the crestal bone is, then we know that that's a problem. There's bone loss there, right? So in anterior teeth, the alveolar crest is pointed and it's sharp. It appears very radiopaque. In posterior teeth, the alveolar crest appears a little flat. It's a little more smooth, and it's a parallel line between the adjacent cemento-enamel junctions, right? So it's not going to be this perfect arch the way it is usually in the anterior. It appears a little less radiopaque than it does in anterior teeth. Sorry, my cat just like jumped on the table. And that's okay. It's not quite as radiopaque because it's a thicker structure, right? We're looking at more space there. So it's okay if it's not quite as perfectly arched and it's not quite as radiopaque, and that's okay. It doesn't necessarily mean that it's unhealthy. All right, so just like we just spoke about on that last slide, the periodontal ligament space is going to be a thin radiolucent line that goes around the root. It surrounds the root of the teeth, and it's in between the root of the tooth and the lamina dura. It is continuous. It means it completely surrounds the root structure, and it should be of uniform thickness in healthy teeth. That is important, okay? So if we start to see a widening of the PDL, the widening of that periodontal ligament space, then that's of concern, okay? That's something that we need to address if we see it widening. So it should be the same width, the same size all the way around the tooth. You can see that lamina dura. See how it comes all the way around this tooth? It's that dark line that completely encases the bottom of the tooth. That is where those Sharpie fibers exist that reach from the lamina dura all the way out to the cementum of the tooth. That is what is holding those teeth in there. The periodontal ligament space is vital for the health of our teeth and for the function of them as well. If we didn't have that periodontal ligament space, we would have a very difficult time chewing our food or talking, or if people ground their teeth and they didn't have a periodontal ligament space, their teeth would just break off because that space gives us a little bit of give. It gives our teeth a little bit of wiggle to them. That's a good thing. Now, we don't want too much mobility, right? That's not good. But that little bit of mobility, that little bit of give helps our teeth to properly chew up our food and speak and bite down on things. It's essential for holding our teeth into our mouth. So don't forget about the PDL, okay? This is just another image of the periodontium. So here, we can see this perfect sort of white line all the way around the tooth. That's the lamina dura. And we see this perfect dark line, the radiolucent line. That's our PDL, or our periodontal ligament space. And then all of this bone here comes all the way up, it crests, and it comes all the way back down. That's a good thing. It's okay if it comes across straight or if it has a little bit of an arch to it. That's a good thing. Now, we don't necessarily see here, you can see like this is, you can see the lamina dura really well here, and you can see it really well here, but you can't see it quite as well right there. Right? That is actually an indication of a little bit of fuzziness there. So this this crestal bone over here is actually beautiful. So that alveolar crest there is beautiful. This alveolar crest, beautiful. This alveolar crest, well, we're seeing a little bit of like a darkening to it. So this is an area where, that person actually might be beginning to have a little bit of inflammation there. Even though this is an example of a healthy one, it's okay. They're looks like they've been through some things here. They've got a couple fillings. Okay, so the description of periodontal disease. Periodontal disease is a group of diseases that affect the health, or that affect the tissue around teeth. So it ranges from superficial inflammation, superficial meaning not very deep, right? It's more towards the surface of inflammation of the gingiva, to the destruction of supporting bone and periodontal ligament. The gingiva would appear swollen, red, and bleeding with soft tissue pocket formation. So in gingivitis, right here, we'll talk about the different classifications, but the gingiva does appear swollen, red, or bleeding. Now, in periodontal disease, the gingiva may or may not be swollen, red, and bleeding, okay? Just because the tissue isn't responding or isn't showing signs of disease doesn't mean that patient doesn't have disease, okay? It just means that the gingiva isn't showing it. We could still have the bone down here that is showing disease, okay? We don't necessarily have to see the tissue looking the way that it might, okay? More than likely it will, but not always. And the other thing, we might see the tissue looking a certain way, but we also need to see that the bone loss is here. So when we look at our radiograph, we're able to see this bone level come all the way down. Right here, this is where the enamel is. Right here is where that bone level should be, right? But we've lost a significant, this is where the bone level is. We've lost a significant portion of bone. Here is the apex, right? Here is where that bone, well, this is where the bone level should be. I mean, we've lost about 50% of the bone around this tooth. And so that's not good. This is where the bone should be. This is kind of where the bone is. This is where it ends. 50% of the bone around this tooth. So it has a lot less support than it should. Okay, so in the detection of periodontal disease, not just the description, but the detection, we need both things, both a clinical examination and a dental image examination. One without the other is not a full diagnosis. It's not a full detection of periodontal disease, okay? You can't examine them just clinically and not have images, and you cannot, I know what you're thinking. You can see it from a radiograph, right? You can't. I mean, you can kind of tell. You certainly have a good indication, but you cannot 100% say whether or not it's periodontal disease without the clinical examination as well. So just like I was saying, the detection requires both clinical and dental image examinations. The clinical exam provides information about the soft tissue. The image examination provides information about the bone. Now, the reason I'm saying this, you can't have one without the other. If you try to do SERP, scaling and root planning, on a patient, and you send that claim to insurance, and you only send radiographs without the perio chart, they'll kick it back to you. They won't pay for it. If you only send perio chart without the radiographs, they'll kick it back to you, okay? So it is imperative that you understand that both of these things have to work together. They have to be in conjunction, and they have to be saying the same stuff. So if I say that there's a 7 millimeter pocket in a certain area, and the bone in that area is straight across, there's no way I stick my probe down underneath their bone, right? There's no way. So it's really important that we're using these two together, and they're saying the same things about each other, okay? So the clinical examination must be performed by the dentist and the dental hygienist. When it says performed by both, I've never worked in an office where the dentist went behind me and measured my perio charting for me. Typically, they don't do that. They trust you to measure these things. We get qualified on measuring these things, but just because we have perio probing depths doesn't necessarily on its own indicate periodontal disease. It's pretty good indicator, but it's not 100%. So what we do is we do our evaluation, our perio charting. We'll go through, we'll take the radiographs, and we'll present both of these things to the dentist. Now we know, but it is not within our wheelhouse here in the state of Texas to diagnose periodontal disease. And so both of these things are presented to the dentist, and the dentist is the one who gives that final diagnosis. And they are the ones who say yes or no. The things we need to be looking at for our gingival evaluation, our gingival description, and our perio charting would be things like redness or bleeding, swelling. Pus is a really big indicator of infection. And then the thorough clinical assessment also, it has to include periodontal probing. Okay. So whenever clinical evidence of periodontal disease is present, you also have to have x-rays to show, again, if I say that there's a 7 millimeter pocket there, but then there's no bone loss in that area, it's a little suspicious that I got a 7 millimeter pocket. So this is going to happen to you guys in clinic. You're gonna be, maybe at a different angle, or something crazy is going to happen. You're going to say the pocket is one thing, and we're going to look at the x-rays, and it's going to be like, well, maybe the pocket isn't really what you said it was. That's okay. That's okay. Like, it's part of learning. But it takes a lot of time. I mean, there's some times where in private practice, I would, I'd get a 3 because I was not quite in there. And then I'd look at the x-rays and I'd see, oh man, there's a lot of bone loss there. So then I would go back and double check myself, and I'd be like, oh yeah, that's not a 3, that's a 5 or a 6. And so it happens to you. And as you learn, as you grow, you'll learn to use those radiographs and the charting together. Okay, so this dental image examination, this is talking about which series of x-rays we would take, right? That examination is how many x-rays we take. Okay, so it provides an overview of the amount of bone present. It's going to indicate the pattern, the distribution, and the severity of bone loss. The periapical image is the image of choice for the evaluation of periodontal disease. There is a reason your book says this. There is a reason that I don't always agree with that, and that's okay. The paralleling technique, we're just gonna talk about what the book says first, and then when we get to this next section, we'll talk about why your book says this, and we'll talk about the value that it has. So the paralleling technique is the preferred periapical exposure method for demonstrating anatomic features of periodontal disease. The reason for that is because it will accurately record the relationship of the height of the crestal bone to the tooth root. Because periodontal disease, we're not just measuring the amount of bone loss, we're also measuring the amount of remaining bone. Okay, this is important because if we were to tell our patients, your root is, you've lost, 50% of the bone in that area, we wouldn't be able to accurately measure that with just a bite wing. Okay, so while our bite wings are one of the best indicators as far as having the best angulation and showing us some of that beginning stages of bone loss, when it comes to 100% accurately recording the bone loss, the bone levels on our patient overall, we need to not only look at how much bone they've lost, but how much bone they have remaining, which forces us to look at our PAs. Okay. Completely don't use is the bisecting periapical image, because it says appear to show less bone than is actually present. That is because of the amount of distortion that you have in all of that, because of the amount of foreshortening, because of the angle, right? So don't use bisecting. Always use paralleling technique with the PAs, and you have to have those PAs when you are initially diagnosing periodontal disease. The horizontal bite wing has limited value. It has value, but unfortunately, it's only the initial look, right? So when we take our bite wing, if they have severe periodontal disease, when we probably can't even see the crestal bone. If they have any bone loss, right, and we can't see the apex, we didn't even take a PA, then we're not going to be able to see how much bone they have remaining. We're not going to be able to see some of those factors of causing bone loss. And so it's important when you are looking to initially diagnose periodontal disease that you get the full mouth series with all of those PAs. Okay, and then especially in the anterior, you don't have any bite wings of the anterior, so you'll take PAs of those areas as well. We have talked about vertical bite wings being um, the radiograph of choice when it comes to measuring for severe bone loss. And so the vertical bite wing can be used to examine bone levels in the mouth when there is more bone loss. But your book talks about using it as more of the checking up, like after they've had treatment kind of image examination, versus using it as your initial one, which we've talked about, the first time your patient comes in, you take an FMX, and then, you highlight them for, okay, next time we're taking vertical bite wings on them instead of horizontal bite wings. It also brings up the panoramic image, which has very little diagnostic value in the detection of periodontal disease. We can look at it, it can kind of show us some, but it's just not something that we can use to measure. So just like we talked about before, those dental x-rays cannot alone be used to diagnose periodontal disease. They do not provide information about the condition of soft tissue or early bone changes. And so, there are aspects to our evaluation and to our assessments that we have to get through that clinical measuring and that meticulous describing of the gingival tissues. They are two-dimensional representations of that three-dimensional object. I talk about this all the time. So buccal and lingual areas are very difficult to evaluate on these. And then bone loss can also be very difficult to detect in furcation areas. So it's really important. So we can see it once it becomes severe, but at the beginning of the bone loss, when it comes to furcation areas, we really can't see that area. The furcation area being that space that's in between the roots of those teeth that have more than one root, right? Okay, so we have to be familiar with the appearance of periodontal disease, and then we're going to talk about what each one of these looks like. So we're going to go through the interpretation of the periodontal disease with bone loss, classification of periodontal disease, and the predisposing factors. Okay, so first up on the interpretation of our for periodontal disease on our dental images is we should be looking for bone loss, right? It's kind of the first thing we all think of when we think of periodontal disease. So we're going to need to look for bone loss on our radiographs, but we also need to look for some of those predisposing factors that contribute to periodontal disease, or they contribute to bone loss. And so what we might be looking for are a couple of other factors. And we need to look at, one, the bone, and we also need to look at the factors that cause the bone to look the way that it does. So those two things, the level of bone and what might be causing that level of bone, are the two things we look at in the interpretation of periodontal disease. Okay, we're going to talk about each one of these. Okay, so bone loss, it talks about it being as the estimated or the estimation of the difference between the physiological bone level and the height of remaining bone. And what that means is the physiological bone level is where the bone is supposed to be, where it is on a healthy individual, right? That 1.5 to 2 millimeters below the CEJ. And then the height of the remaining bone is where that bone level is on that tooth, for that surface of that tooth, for that specific individual. Okay. And so what we're measuring here isn't how much bone is lost, but rather how much bone they have remaining. Okay, so it's not about glass half empty, right? It's glass half full. Okay, so if they've lost half their bone, we're saying they have 7 millimeters worth of bone, not they have 7 millimeters worth of bone lost. And don't get me wrong, we're definitely going to talk about how much bone they've lost. Okay, you're forever from now, we're going to be talking about how much they've lost. But when it comes to bone loss, we're not just looking at how much they've lost, but how much they still have. And a lot of times you'll hear me talk about the percentage. I break it down. So I say, you still have 60% of that bone in that area if they still have 60% versus saying they've lost 40% of their bone. Bone loss we talk about in terms of the pattern. So we'll talk about each of those. We'll talk about the distribution, and we'll talk about the severity. So when we talk about pattern, we mean vertical or horizontal. We talk about distribution. We'll talk about how much bone loss is in certain areas, how much it like generalized or localized. And then we'll talk about the severity being how much bone they've actually lost. So here is that image of bone loss, where the physiological level being that 1.5 to 2 millimeters below the CEJ and the height of the remaining bone. Okay, so that is what we are measuring. Bone loss is estimated as the difference between the physiological level of bone and the height of the remaining bone. The pattern of bone loss is described as either horizontal or vertical. I distinctly remember seeing this on my boards and having to decide whether it was vertical or horizontal areas. And it would tell me, look between these two teeth. Is that vertical or horizontal? And I'd have to choose one. Okay. Horizontal bone occurs on a plane parallel to the CEJ, and vertical bone loss does not occur on a plane parallel to the CEJ. I'm going to show you an example of each of these. So horizontal bone, you can see here on this image, is flat. It's straight across, right? Both sides, both the distal of this tooth and the mesial of this tooth have the same amount of loss. That is horizontal bone loss. Horizontal bone loss occurs on a plane I'm sorry, that's not parallel to the cemento enamel junction of adjacent teeth. Vertical bone loss, which is also called angular bone loss, right? Because it occurs at an angle. Its vertical bone loss occurs on a plane not parallel to the cemento enamel junction, or the CEJ. So instead of occurring straight across like this area has, it's going to dip on one side. I show this to my patients all the time. I say, you see that area where it dips right down? That is bone loss right there. But this is vertical bone loss. When you start seeing patients, you're going to have to go through your radiographs and you're going to say, this is horizontal bone loss, this is horizontal bone loss, this is vertical bone loss. This up here, I have no idea because this bite wing does not show us that crestal bone. So the distribution can be referred to as localized or generalized. Localized occurs in isolated areas, and generalized occurs evenly throughout the dental arches. Localized is 30% or less, okay? 30% of anything or less. It's one area, by the way, okay? So if it's a little bit of bone loss on this area, a little bit of bone loss here, a little bit of bone loss there, but like all the surfaces together still don't equal 30%, that is not localized, okay? That is generalized. If it's, I'm going to show you an image in a minute, but if it's just in one area, there's bone loss here, but everything else, this area is fine, this area is fine, this area is fine, that is localized bone loss, okay? Remember, 30%, 30%. Generalized, more than 30%, and evenly throughout the dental arches. Okay, so this is this distribution. We see this bone loss right here, and we see not a lot of bone loss everywhere else, right? So this is localized bone loss. We see it in just one area of the mouth. It's either 29% or less localized bone loss. This one is horizontal bone loss, okay? We see some bone loss here, we see some bone loss here, we see some bone loss here, a little bit more right there, a little bit right there, a little bit right here. Generalized bone loss is more than 30%. Severity is a little bit different. It's where we start to classify the amount of bone loss that we see. And it can be classified as slight, moderate, or severe. We can also say like slight being 1 to 2 millimeters, moderate being 3 to 4, severe being 5 or greater. It's measured by clinical attachment loss. So when we look at recession. I'm sure you guys have talked about this in preclinic, but there's recession, and then we measure the pocket, the probing depth. We have to add those two together. So it's from the CEJ to the depth of the pocket, no matter if it's covered up by gingiva or not, right? So from the CEJ to the base of the pocket is the clinical attachment loss. Now, 1 to 3 millimeters difference there is normal. That's what we're used to seeing. That's what is still healthy. When it's more than 1 to 3 millimeters, that's when it becomes unhealthy. So if I have 4 or 5 millimeters of clinical attachment loss, then I have slight bone loss. 1 to 2 millimeters is more than what is considered healthy. Then moderate bone loss would be if I had 6 or 7 millimeters of clinical attachment loss, because 1 to 3 is healthy, and then 4, 5, and 6 are, 4 and 5 um, would be 4 and 5 would be slight, and then 6 and 7, my goodness, would be moderate bone loss. And so then severe bone loss is anything that is 8 millimeters of clinical attachment loss or greater. Sometimes you can have areas where patients have a lot of recession, so they have a lot of clinical attachment loss, but their tissue seems healthy. It is still considered bone loss in those areas when they have recession. So we still have to count it. So severity can be measured by the clinical attachment loss, which is the distance in millimeters from the CEJ to the base of the sulcus or the periodontal pocket, right? Clinical attachment loss is the measurement of distance in millimeters from the CEJ to the base of the sulcus. You guys are going to do that a lot in other classes. It's not as much a radiology thing, but anytime I can say these words to you and it can just sink home a little bit more, that's a good thing. The ADA, the American Dental Association, breaks these down into case types, okay? So ADA, we're going to talk about each one of these. ADA case type 1 is gingivitis. ADA case type 2, early periodontitis. Case 3, or type 3, case type 3, moderate periodontitis. And case type 4 is advanced periodontitis. And we're going to talk about each one. Each disease type has a specific radiographic appearance, okay? So we're going to be looking for specific things on our radiographs for each one of these case types. And we can use those images to detect the contributing factors of periodontal disease as well, so we know what's causing this periodontitis that we're seeing. Okay, so ADA case type 1 is gingivitis. Now, when you get to perio, we're going to be talking about the AAP. I'm sure you've already heard this when like the seniors are talking about it. AAP status is like the Advanced American Periodontitis Society, or whoever it is, the perio people. They are the ones who came up with the AAP status types. That is what we use to classify our patients in clinic. And so ADA is different. Don't get these two confused. They're similar. They're like ridiculously similar, but they are two separate institutions creating these standards. And so I don't want you to get them confused. When we talk about ADA case type 1 being gingivitis, which is no associated bone loss, and there's no change seen in the bone when viewed on dental images. So that means that we can see that crestal lamina dura, and the alveolar crest is approximately 1 to 2 millimeters apical to the CEJ. Excuse me. It also means that bleeding may or may not be present, right? Because this, on a radiograph, we can't tell if their soft tissue is healthy or not. And it's okay if in case type 1, there's no bone loss, but the tissue isn't quite healthy, then that's something that we can reverse. That's reversal, a reversible condition. We can reduce the amount of inflammation in the soft tissue so long as it hasn't affected the bone. And so only the gingival tissues are affected. We see this in healthy patients and we see this in gingivitis patients, okay? So here is the ADA case type 2. This is early periodontitis, and it is associated with mild crestal changes. Mild crestal changes being when the lamina dura becomes unclear and fuzzy, and it no longer appears to be a continuous radiopaque line. So on this radiograph, we can see here this little area here. See how this isn't this perfect line right across? It's kind of fuzzy right there, right? Horizontal bone loss is more often the case over vertical bone loss in this type of early periodontitis. Bleeding can occur with probing, although not always. Pocket depths result from attachment loss may be present, and there could even be localized areas of recession. In your book, you can find these images on figures 34-17 and 34-18. Okay, so case type 3, which is moderate periodontitis. Here we see horizontal or vertical bone loss. The pattern can be horizontal or vertical, and the distribution, may be localized or it might be generalized. Sometimes here we even see a bit of furcation involvement, although not always, okay? It just depends. The alveolar bone here is usually approximately 4 to 6 millimeters apical, or away from the CEJ of adjacent teeth. When the bone in the furcation is destroyed, there is a little bit of a radiolucency, this area right here, where you can see that the furcation is it's starting to lose bone in the furcation area. Clinically, in your probing depths, you'll see pocketing and attachment loss up to 6 millimeters. Um, and recession, furcation involvement areas, and there might even be a little bit of a slight mobility. You can see this in your book on figure 34-24. So this is case type 3 or moderate periodontitis. This is more examples of case type 3. So you can see here, this is where the bone is, and this is where the bone should be. So we're seeing about 4 millimeters or so of loss right there. Here's where that tip of the root is. And so here we've lost about a third maybe of the bone of this tooth. And so that is a moderate amount of bone loss. Okay, so ADA case type 4 is called advanced or severe periodontitis. This is a pattern of bone loss that may be horizontal or vertical, right? And we see bleeding on probing almost always. Almost always. It could be vertical, and it could be vertical, but it's also horizontal. This is where bone level is on one side. This is the bone level on the other side, because again, it's a three-dimensional object seen it at 2 dimensions. And so this is where that level should be. So this is the bone level we're seeing here. I'm seeing a little bit of bone as it kind of creeps up over here. So this area here versus this is where the apex of the root is. We're seeing about I'm saying almost close to 50% of this one surface of this tooth. Now, if we look at this one, this is where the bone should be, because the enamel ends right here. And then this is where the bone is on one side. That's where the bone is on the other side. Here's the tip of that root. And so if I drew a line from there to here, where I see the bone, and then from here to here, see how this is it's pretty severe. There's a lot of bone loss here. It's even more than half, I would say. All of this area right here, this is all furcation area that is completely exposed. This is either a class 3 or a class 4 furcation area, which you'll learn about next term. But this is a lot of bone loss. This is very severe. This patient will, staying on this pattern, this patient will definitely lose their teeth in the next few years. And furcation areas are almost always, it's a given when we see case type 4, ADA case type 4 periodontal disease is almost always furcation areas have involvement there. Here we're seeing anything that has 5 millimeters or more. And so if 1 to 3 is normal, then we're seeing anything that is 8, sometimes even 7 or 8 on our probing depths after we calculate our clinical attachment loss. So be aware of that when you are looking for your patients. You're looking for your case type 4 patients, and you are hoping to see this on your radiographs, even though you don't want that for your patient, of course, but you kind of need someone who looks like this. And so when you see it, you need to be able to recognize it. Okay, so predisposing factors. There are factors like predisposing ones or even local irritants that can contribute to that periodontal disease, okay? And so what we need to do when we are we're looking, okay, you're a mild or you're a moderate periodontitis, and We also need to be looking at what's causing this. Is it lack of home care really? Or is it some other type of issue like a predisposing factor or a local irritant that are causing that periodontal disease? It's really important that we discuss that with our patients and we talk to them about, their habits and things like that so that we can eliminate those predisposing factors in that management. So we can't stop periodontal disease. We can't do their SCRP and then maintain their periodontal disease and their bone level if they're not willing to stop doing whatever it is that's causing the bone loss. Like if they're a smoker and they have diabetes and they don't brush their teeth and we clean their teeth and then we see them back 4 to 6 weeks later, they're still going to have the same issues. The bone loss is still going to continue because they haven't stopped doing what it is that's causing the bone loss. And so it's a really important conversation to have with your patient that this isn't on you. It's not your responsibility to stop their bone loss. Yes, it's your job to get the calculus off, but it's not your responsibility to stop their bone level. It's their responsibility to stop their bone level. And building that rapport with them and having that communication with them is so crucial so that they understand and they take responsibility for this. You won't find too many people who blame you for why their periodontal disease continues to progress, because most hygienists are pretty good at letting the patient know that this is what you're doing and this is what you should be doing, kind of thing. But you'll still see some patients. You can talk to them till you're blue in the face about the things that they need to be doing and how they need to be flossing and how they need to be caring for their teeth, and it just doesn't matter to them, and their disease will continue to progress. And so anyway, back to predisposing factors. The effects of certain medications, tobacco uses, systemic conditions like diabetes or autoimmune diseases, or things like that, heart disease, those will all raise the risk of periodontal disease. Now, is there any actual scientific study that shows that periodontal disease causes any of those things? Um, it's squirrely. You're going to learn about that in next term. All of those factors play a role in how your body reacts to bacteria. Okay, so diabetes, heart disease, tobacco use, certain medications, they all play a role in your body's immune reaction. And your body's immune reaction, coupled with the bacteria and the effect the bacteria has on your body, those two things together play a role in periodontal disease. Okay. Um, and then, of course, we have dental images. The radiographs help us to find things like calculus and defective restorations. So while we're not going to be able to know if they are taking a medicine that causes xerostomia, we're not going to know that from our images. With our radiographs, we're going to be able to tell calculus and defective restorations, and those two will play very large roles in periodontal disease for your patients. Yeah, sorry about that last slide. I got a little excited about all that. Anyway, calculus. This is probably going to be on your board exams as far as being able to recognize what calculus looks like on a radiograph. So calculus results from the mineralization of plaque. Where does that mineral come from? Your saliva. That's where it comes from, or gingival gravecular fluid. So those are the two sources of mineral in your mouth. They appear white or light on a dental image. Over time, they become more and more dense. Your saliva actually mineralizes the plaque if it's left on the tooth. And the longer that it's there, the more dense it becomes. And as we know, if things are dense, they start to show up on x-rays. If they're not very dense, like plaque or early calculus, then they don't show up, right? So even though we might not see calculus on our radiographs, that doesn't mean they don't have calculus, okay? Just keep that in mind. Most often, on a radiograph, it will appear as a pointed or irregular radiopaque projection extending from proximal root surfaces. And what I always like to tell people is that it's this little white thing hanging off the side of the tooth, or it's like a little spicule or a little spur hanging off the side of the tooth. And that is what calculus looks like. It can be a ring-like radiopacity, so you can see sometimes it's like this little sort of ring going around the tooth. Sometimes it's a nodular image projection, like what we see here. These are kind of more nodule. And then sometimes it could even be a smooth opacity on a root surface. Sometimes it'll be burnished, right? Sometimes the hygienist who came before you, she did her best, or he, of course, and they tried and they smoothed it down, and now it's a smooth surface. It's burnished calculus. It's pretty difficult to get off once it's burnished, but that's okay. We'll do our best. We always, all of us, we all do our best. All right, so this is a very good example of what an ADA um, case type 4 looks like, but you see all this bone loss, and then this is where the bone is. It's definitely a little bit more than 50% of bone loss here, but anyway, we're looking at the calculus. So this sort of weird irregularity right here on the side of the tooth. That is calculus. On this side, we see it right here. Here we see it, there's like fuzzy little sort of squiggles on the side of the tooth. That is calculus on our radiographs. It is a stone-like. After it's been there for a while, a couple of years, it actually becomes almost as dense as the tooth itself. It's going to feel like cement trying to get that thing off, okay? It becomes very, very dense, and it adheres to the tooth so strong that it is imperative that you learn in preclinic the angle of instrumentation as far as getting that 70 to 80 degrees of that blade right up against that tooth so that you'll be able to like you place your blade here and you sort of scrape it right off, and it pops off in little chunks on you. That's imperative that you learn that skill, because otherwise you're going to be kind of just sliding right past it, and you'll be burnishing it down for the next hygienist. Here in your book, you need to look at figures 34-28 and 34-32 to be able, I'm sorry, 34-28 through 34-32 to be able to see all of these wonderful examples of calculus. I see these images, and I just have an itch to like go scale that tooth. You'll get that way. It's like it's just gonna feel so good when those teeth are clean. It's gonna be so satisfying. All right, and here's another image of that. You can see this calculus right here on the side of this tooth, and you can see this big old spur right here on the side of this tooth, and you can see a whole bunch of fuzziness stuff right here. That is all calculus right there. This area right here, this is a very large radiolucency on the side of this tooth. Now, I can't say whether that's a cavity or not, but it is definitely suspicious. Here is another example of that calculus. This one is a lot more like a spur on the side of the tooth. This one looks like it might have been burnished at some point. It looks like somebody didn't use their 70 or 80 degree angle, and it looks like this now. This area down here, this is calculus as well. This is going to be a very difficult area. This is burnished calculus right here too. These are going to be very difficult to get off because it's underneath the crown, and so sometimes, especially inexperienced hygienists, they have a hard time discerning the difference between a margin of a crown and the bottom of calculus. And so for the rest of the time that you guys are around me and you are feeling calculus, I'm going to be right there saying, do horizontal and oblique strokes. Do them. Horizontal and oblique strokes will help you get calculus from underneath crown margins, okay? Vertical strokes will help you feel the margin of crown, okay? We'll talk about how to feel calculus with a vertical stroke in approximately, but and how to discern the difference between a crown margin and calculus with a vertical stroke. But if you want to get this calculus right here, this piece right here, you do a horizontal sweep across the back of that tooth, you're going to get that calculus, okay? Okay. All right, so our next topic is defective restorations. And I mean, we're going to go through a couple of these. You could look at images all day with defective restorations. So faulty restorations act as food traps, okay? The bacteria, because the tooth is not contoured the way that it should be, the way that it's meant to be, that contour of the tooth really, really helps to keep the tooth clean and to prevent trapping food in between teeth. And so when the restoration doesn't go along with that, perfectly engineered contoured structure, then there are problems. And so it traps food there and it leads to the accumulation of food debris and bacteria. You can look at this both clinically and on dental images. You'll see it a lot on dental images. The types of restorations that this sometimes happens to, fillings and crowns, right? But the faultiness, the part that makes it defective, will be if it has open or light contacts, right? Two teeth, when they touch each other, the tighter those contacts are, the less food you'll get stuck down in there. If it's nice and open, it's kind of like just this perfect little valley for food to get stuck down in. A poor contour is like an overhang, right? Or it's kind of flat instead of curved. That would be a poor contour. And then uneven marginal ridges. So if the crown, the margin doesn't go evenly with the tooth, it doesn't smoothly lay down against it, then it will trap food underneath the margin. An overhang, which we've talked about as amalgam overhangs, but you can certainly get an overhang with a composite or, anything, any type of material, gold, I guess, will have an overhang. If the material sticks out further than the tooth does, then it will trap food underneath it. And then inadequate margins are when a crown goes onto the tooth, but the margin of the crown doesn't go all the way down to where that prepped surface is of the tooth. So it's considered an open margin, and an open margin gets food stuck in there, of course, if it's open. So here is an example of a poorly contoured crown. This is on page 423 in your book, and you can see these terrible, terrible. These are actually metal pins right here. The dentist isn't quite as bad as you think he is, but or she, of course, I'm sorry. So this sort of line of this crown, it looks like that, right? It just comes straight across. That's a terrible, gosh, my bad. I don't know if I can draw a straight line with this mouse, but anyway, it should come just straight across. And so anytime you have all these squigglies there, that's an opportunity for the margin to not fit on there perfectly, and over time um, it'll cause bone loss around that tooth. The same thing is happening up here. You can see this crown way out here, and then it kind of comes around and it comes here. The front of this one actually is really nice, but the back side is kind of not great. And then you can see here these little pins sticking up. These are metallic pins or retention pins. This is an example, another defective restoration. This is an amalgam overhang. And you can see here how, because this amalgam is sticking out way far on the side, it is causing a very blurry mass right here in between these teeth, right? And we don't want that. We want this perfect solid line. So probably before they had this filling placed here, they had a wonderful, beautiful lamina dura, crestal bone, wonderful. Everything was good. And now it looks like this. It's a little fuzzy. It's becoming kind of indistinct. And unless they get that filling fixed, they're gonna continue to have bone loss in that area, it's really sad. You have to think about the responsibility that a dentist has, not in just making people happy and paying for all the stuff around the office and doing all of that, but their work could actually cause damage and could cause periodontal disease on patients. And I don't know about you guys, but that's a lot of responsibility to have. Whoa, there's a lot going on in this image. So yeah, once again, we're seeing that ADA, severe periodontal disease, right? Severe, and there's a lot of fuzziness going on here in these ones. The contrast and density of this image isn't really that good. And oh, this right here is our identification dot. We never want to forget about him. There's some root cavities here. That's what this one looks like, and that's also what this one looks like. And patient has a root canal and a post and core here. Actually, let me get rid of that image, the little line I just drew. Remember we talked about how there's gutta percha on this section, and then there's the post and core here, and they don't even have a crown on this tooth. This is just a really big filling here. This is a natural tooth on the backside. So there's just a lot happening here. And then this is probably a cavity right here. You can see that really weird shaped thing there, and then there's a little part right here at the top. Gosh, and it looks like they've had some scaling done, but it was not a good scaling. They have this amalgam overhang. You can see how flat these fillings are. I don't know who did this, but they messed them up. So they've got very flat, and it's very important that we get this nice contour to a tooth, right? We need that curve. We like curves here in dentistry. So here, the examples we're seeing are uneven marginal ridges around some of these teeth here. We see open contacts, this big old honking space right here. We see overhangs like this one, and we see poorly contoured, let me get rid of this squiggles I drew here. We see poorly contoured restorations because it's so flat. We need curves. And yeah, this patient is not in good shape. A couple of other things we see about this image is that it is placed either too distal or too mesial. I'm guessing it's too mesial. I'm guessing it should be a molar bite wing, but the patient doesn't have any maxillary molars up here, so that's probably why they needed the patient to be able to bite just a little bit on the bite tab. And so that's might be why they moved the film up a little bit, or maybe, well, I mean, this is the dentist they work for, so they might not they might not know how to take these properly. But yeah, so there's a lot going on here, and then the contrast and density isn't quite perfect. It's okay. I can see the pulp chamber here. I can see the DEJ, so it's not that bad. What else? We can also, oh, well, yeah, I mean, we can see crestal bone everywhere, so it's actually pretty good considering the amount of bone loss we have here. It's actually a pretty good horizontal bite wing, right? Because I mean, most of the time you think about this much bone loss, you'd think you'd have to use a vertical, but they captured both, bone levels, so that's good. Yeah, but there's a lot happening here. All right, so that was that. Probably the most important chapter you'll see for this course. There's a lot of other very important chapters, but periodontal disease for a dental hygienist is pretty important. Being able to recognize it on a radiograph is pretty important. I'm sure these are things that even, especially if you've worked in an office, but even if you didn't, you kind of were already starting to look for this sort of bone level thing. And I'm sure when you see it, you kind of already recognize that, hey, that's not a good thing. But now we have tools to be able to recognize it, to be able to measure it, to be able to look at maybe some of those other factors, those terminology that we needed to have in order to describe what exactly it is about this image that didn't quite look right, right? And yeah, now we can see too in a lot of those others that there's a lot of things that could cause periodontal disease that aren't just brushing and flossing, right? So if you have questions, please ask them. And other than that, that's going to be that for chapter 34.